everyone. We're going to get started right now with Dr. Nalabaki, our cardiologist, and we're going to get started and ask your questions as we get going. Here she is.
Making sure we get this program set up and making sure that we take care of those patients who have those heart failure needs here in our community. Dr. Nalabaki has been trained in this area. She also focuses on women's heart health as well. So I'm going to let her, she's the expert on her as well. So I'm going to give her the opportunity to give a little introduction and just please join me in a round of applause and thank you, Dr. Nalabaki, for being here tonight. Thank you.
Hi, welcome everyone. My name is Purna Nalabaki. I moved to Salt Lake City in August from Houston, Texas. I trained the last 9 years back in Houston at University of Texas and Houston Methodist. I did my advanced heart failure and transplant fellowship before I moved in here. My passion and my interests are in the field of heart failure, and I will go through the data of the heart failure, and there is an immense need in the field of heart failure. And as you all know, this month we're celebrating Healthy Hearts. So we've been doing this since 1964. So this is the month where we remind ourselves about our heart health and what are the best things that we can do to keep our heart healthy. So let's get started with our talk today is heart failure treatment and prevention. So going back to cardiovascular disease. So cardiovascular disease is a vast term, which includes a coronary artery disease, heart failure, and a valvular heart disease, and also an abnormal heart rhythm. So all these include cardiovascular disease along with stroke and peripheral vascular disease. So cardiovascular disease is the leading cause of the death globally, more than 17.9 million every year. And it's expected to raise more than 23 million by 2030. Every day, 2,300 Americans are dying because of the cardiovascular disease. If you take an average, every 38 seconds there is a death because of the cardiovascular disease. And February is the American Heart Month. It's federally designated since 1964. It's an ideal time to remind everyone to focus on their heart and also encourage them to get their families, friends, and the communities to be involved. So now we're focusing more on the heart failure. So can anyone tell the first, who's this in this picture? Great, yes. So going back to his medical history, which is probably is not a HIPAA violation because it's there on the web. So he was a smoker, was a heavy smoker, and he had his first heart attack by age 37. And then subsequently he had 4 to 5 heart attacks, and he went for open heart surgery. And then he developed congestive heart failure secondary to his coronary artery disease. In 2010, his congestive heart failure was so advanced and there was no medical therapy left. He went on to get a left ventricular assist device. It's a pump that helps the heart to pump the blood to the aorta. So he got it in 2010, and he successfully went on to get a new heart transplanted by 2012. He's out 5 years, doing great. And can someone name this beautiful lady?
Elizabeth Taylor.
Yeah, that's great, yes. So she was also a victim for heart failure. She was diagnosed with heart failure in 2004, got treated medically, and then finally her cause of death in 2011 was congestive heart failure. So that's the history. Then now, move on to present and future. So what can we do? Is there anyone in the audience is a heart patient or has a heart condition? Please raise your hands. So congestive heart failure, we define this as the heart is unable to pump blood at a sufficient rate to meet the metabolic demands of the body, which is the oxygen and the nutrients. So is heart failure is just a disease? No, heart failure is a syndrome. And the heart failure is a complex clinical syndrome. It resulted from a structural or functional cardiac disorder that impairs the ability of the ventricles. Ventricles are the lower chambers of the heart. So when they get impaired, they cannot no longer function well, either to fill the blood inside or to eject the blood. So whichever can cause the heart failure. So why do we care about the heart failure diagnosis? So there are a lot of medical conditions, but why should we care in particular about this heart failure? So as of now, Centers of Disease Control, the data shows there is 6 to 6.5 million existing cases as of today. And more than 500,000 cases are diagnosing every year to add on to this 6 million prevalent cases. And there are 1 million discharges every year, costing the health system $39 billion. That's the health cost for the hospitalizations for heart failure, which is vast. And it's estimated to increase this cost by $60 billion by year 2030. And if we take the patients who are Medicare 65 age and above, heart failure is the leading cause of the hospitalization. And those who are hospitalized, 1 in 3 are dying at the end of the year. Even the first hospitalization or second, once they're hospitalized that year, 1 in 3 are dying by the end of the year. So that's the heart failure prognosis. And then coming to men or women who are sitting in the room anywhere in the world, 1 in 5 men and 1 in 5 women they have a chance to get the heart failure, so 1 in 5. And if you look at the hospitalization trend from 1979 to 2004, either blue in men or women in pink, so the trends are raising. And even the first hospitalization here, the trend is raising, or the second hospitalization, the trends are raising. The similar condition in the men and women. Moving on to the next slide. So is heart failure is a single condition or is any different types of the heart failure? So the heart failure can be 2 different types. So in 1980s and in 1990s, so we know mostly heart failure is called as heart failure with reduced ejection fraction. And now there is a new entity that's being raising in the last decade is called heart failure with preserved ejection fraction. So what does that mean? So here, so let's see here. So it's called systolic heart failure or the heart failure where it's called heart failure with reduced ejection fraction. So what happens here is this is your left ventricle. So I'll take this moment just to explain the structure of the heart. So this is the top chamber, it's called right atrium, right ventricle, which sends the blood to the lungs through this pulmonary artery. And this is the left atrium, this is the left ventricle, which carries the red blood from the lungs and then sends the blood to the aorta. So the important chamber is the left ventricle and as well the right chamber. So when there is a systolic heart failure, this left-sided chamber gets weak and it can no longer pump the blood to the body, to the aorta. That's called the heart failure. Now, the new entity that's raising, and the incidence also increasing more than 50%, is diastolic heart failure. Here, the heart muscle is not weak like here, and here the ejection fraction, where the pumping ability of the heart is okay. But because it's being so stiff and thick, the pressure is raised inside, and the blood cannot fill through this ventricle. As this chamber cannot be filled effectively, so it cannot pump the blood through the aorta. So either because of the weakness of the muscle or because of the stiffness of the muscle, the end result is they are not pumping the blood that needed for the rest of the body effectively. So that's the final pathophysiology. So as I mentioned, so what does the systolic heart failure do? So decrease in the left ventricular function and also decrease in the total cardiac output that sends out. And in the diastolic heart failure, normal ventricular function, and there is elevated pressures both in the right and left ventricles. And now, so what causes this heart failure? So what are the causes that we need to know, or if we have a condition, are we predisposed to heart failure in future? So this is very, very important slide. So number one cause of the heart failure is ischemic heart disease. What does that mean? If someone has bad cholesterol, which forms plaques inside the blood vessels, and over the time it gets bigger and bigger and occludes the blood flow. And when it occludes the blood flow, dynamic, so it causes less blood supply to the heart muscle, and also patients experience angina, and over the time the muscle, because of the lack of the blood supply, gets weak and finally die. So that's called ischemic heart disease. So 40% of ischemic heart disease can lead to heart failure. And then the second most important cause is dilated cardiomyopathy. So it's a garden variety of diseases put together in this. I'll go over every single cause here. And then again, very important to know, high blood pressure. High blood pressure can predispose a person in their lifetime for a congestive heart failure. And then valvular heart disease. So what do we mean by valvular heart disease? So if you remember the heart diagram before, so when these chambers are squeezing and sending the blood through the valves, they do so through the valves. And so either these valves can be very narrow, or these valves can be stretched and leaky because of different pathophysiologies. Everyone might have heard of rheumatic fever. That was one of the most common cause in the past for the valvular heart disease, but current era could be calcification and other reasons are infective endocarditis. So these are the reasons for valvular heart disease. So coming back to dilated cardiomyopathy. So under dilated cardiomyopathy, so 50% are idiopathic, but let's go over it. So chemotherapy, certain chemotherapy which is given to cure the cancer will put the patient at the risk of heart failure. So the most important chemotherapies that can cause heart failure are the chemotherapy that can cure the breast cancer. And here we're happy that the patient got rid of the breast cancer, so she's in remission. But down the road, 4 or 5 years, she gets shortness of breath, her feet are swelling, she's coughing, she doesn't know what's going on. And then this is heart failure secondary to her medications given to treat her cancer. And then connective tissue disorders. So either SLE, rheumatoid arthritis, scleroderma, because of the inflammation, they're more prone to get the congestive heart failure down their road. And then HIV is known cause. It's 4% to cause this congestive heart failure. And infiltrative diseases. So infiltration means an additional material which is not a component of the myocardium comes and deposits in the myocardium and causes this heart failure. And example is sarcoidosis and amyloidosis. And then peripartum is a very important entity. So women, childbearing age, so they have their child and postpartum, like, after a few days or few months, so they start to feel like their heart palpating and it's racing up. They started to have shortness of breath, and again, like their feet are swollen, and that's peripartum cardiomyopathy incidence is actually growing right now. And women, if they have a subsequent pregnancy after they're diagnosed with the peripartum cardiomyopathy, the chances of death are very, very high, and the pregnancy can be very, very high risk pregnancy. And the toxins, and one important one to mention is alcohol. So what does alcohol do is it makes the chambers to dilate and more weaker. It's called dilated cardiomyopathy, secondary to the alcohol intake. And the most important thing is we know how to cure it. Just stop taking alcohol. So that's one of the reversible cause. And here, myocarditis. Here, in the myocarditis, it can be because of the viral illness. So like mostly young patients, they're exposed to a virus, they get a viral illness, and they feel better, but after 2 weeks, they can't breathe, and they can't do anything, extreme fatigue. So, and these viral myocarditis are extremely, extremely dangerous, and it can cause sudden cardiac death. And rest of the green 17%, so if any of you heard a condition called atrial fibrillation, if it's untreated for so long, and it's called tachycardia-induced cardiomyopathy, it can cause congestive heart failure, and it's a very common situation that we see mostly in hospitals. And congenital heart disease can lead to congestive heart failure. And there is a very important entity that we've been seeing for the last decade. It's called stress-induced cardiomyopathy. So either the stress from the spouse, or from the neighbor, or could be just like, we're in the line and someone cut the line, I don't like it. Yeah. So we do not like many things. So that my experience that so far I have seen many cases, but I remember one case that the patient came into the hospital for dehydration. She got treated, getting ready to go. And then her son came, they had a disagreement where to go, to her house or to his house. And then we got a call from telemetry, hey, she has ST segment elevation, she has myocardial infarction. So we rolled her to the cath lab, boom, her coronaries were normal. The stress caused her heart to balloon, like an octopus pot. It's called stress-induced cardiomyopathy. So again, to remind everyone, it's a busy life. Not to have stress is common, but just don't take it too serious. And then again, Chagas disease, the incidence is low here, but always make sure if you travel to South American countries, so the Chagas disease is seen there. So the most common question that I always ask is heart attack the same as heart failure? So I would say these two are different entities. So heart attack is, there is a plaque that you're seeing here, and then this plaque can rupture, and then sudden cessation of the blood to the rest of the myocardium or the muscle, and it causes myocardial infarction. That's called sudden heart attack, and it can cause sudden cardiac death. Whereas heart failure is a subsequent stage of this heart attack, or the heart failure is gradual weakening of the muscle, whereas the heart attack is sudden. It happens sudden. And so if there is a lot of data, and they looked at like 400,000 patients who are above 65 and who are below 65, and they compared both the groups. So in these both the groups, so what are the comorbidities these patients have, so that we know that if anyone has these comorbidities, that means their chances of developing heart failure are higher. And also there are certain comorbidities when a patient has, then we have to be more cautious because they do perform poorly. So what are these comorbidities? So one is high blood pressure, other one is coronary artery disease, and diabetes is the number 3rd. Diabetes and hypertension, which is high blood pressure, they seem to be simple. Oh, I have blood pressure, I'm taking medication, I'm fine. But at the same time, you have to ask yourself, is your blood pressure controlled? Are you taking precautions so that your blood pressure won't go up? Are you following the diet and lifestyle modifications? So you got to do all this when you have high blood pressure. Same as diabetes. I have diabetes, I'm taking metformin, I'm good. But at the same time, one thing that you don't know is your blood glucose is already acting on your kidneys, already acting on your heart, and already acting on the blood vessels everywhere. So these are the 2 silent killers. So if you have these conditions, so just make sure you know your numbers and you make sure that you have already educated about what can happen subsequently with these 2 conditions. And then high cholesterol, having a low blood count. I have hemoglobin 9, but I'm okay. Probably you need to talk to your healthcare provider. Probably that's not okay. And having chronic kidney disease, where chronic kidney disease can happen either because of the high blood pressure and diabetes. These are the 2 most common causes. So having kidney disease itself in heart failure patients, their chances of deterioration is more quicker. And depression is also very well associated, both less than 65 and more than 65. So COPD and asthma, these are the 2 lung conditions are frequently seen in heart failure patients. So heart failure, I've been talking so far that, okay, heart muscle got weak, or heart is so stiff that it cannot fill the blood. So what? Why does heart failure cause this many symptoms? It's just the heart muscle weakness, right? So why I have fluid in the feet, why I have fluid in the lung, why my blood pressure either low or too high, just because of the heart muscle. So what's happening here is, yes, so the heart muscle got weak, then it cannot pump the blood. So that's the story so far we have known. Then our body has defense mechanisms. What they do is, so these defense mechanisms, there is baroreceptors. They are in the left ventricle. They are in the aortic arch, the big vessel, and also in the carotid sinus. So as soon as they detect that the heart is not pumping enough, so, oh, the heart is not pumping enough, I have to help the body. So they help secreting certain hormones which they think they're doing a great job, but they act in a different way and they're not helping, but they are causing your blood vessels to constrict so that your white blood cells doesn't get enough of blood. And they also secrete certain hormones. They're called aldosterone and angiotensinogen 2, which further secrete the other hormones. Finally, they all think that, okay, so our body does not have enough fluid, so let's say more water and fluid to the body. So now they're constricting the blood vessels, they're retaining the more salt and fluid to the body, so the patient will see fluid in the lungs and fluid in the feet. So these are actual all pathophysiological mechanisms that's making the heart failure more complex. So this is a very, very important slide. So what are the common signs and symptoms of the heart failure that everyone should know? Because at least a quarter patient that we get to the heart failure clinic, so they've been already gone to pulmonology, they've been already gone to allergy, or they're on the anxiety medication because The most common symptoms can be like a cough and also the pressure inside the chest or palpitations. And they perceive these symptoms that, oh, like I'm getting anxious, so they try to breathe. And after a week, it doesn't go away because it's heart failure, so they go to the doctor. They'll be given medication, antidepressants or allergy medications. And then they'll spend 3 more months, and then they don't feel well, come to the hospital. That's when you find their heart is not working well. So the common signs can happen either because of the congestion, because the heart can no longer pump, so all the fluid is backed up and all the pressures are backed up, and because of the congestion, so cough is the symptom, and also dyspnea or orthopnea. So these are described as when you walk either flight of stairs or when you walk more than 300 feet, you get tired, you get short of breath. You no longer can walk because you're like gasping for air. That's called dyspnea. And orthopnea, PND, so these are described when you lay down flat, all the fluid rostally distributed from the feet to the heart and lungs, and causes fluid in the lungs, and they no longer can breathe in the flat position, so they wake up in the middle of the night. And they have to use more pillows, they have to be semi-recumbent, or they have to sit up to breathe. And heart failure, interestingly, can cause anorexia or cachexia with loss of appetite. So that's called cardiac cachexia. And also, we all know heart failure patients are identified with their abdominal distension or swelling in the feet. It's called edema. And also this patient can experience a right upper quadrant pain, which most of them are screened for gallbladder stones. But actually, because of the congestion of the liver, the liver capsule stretch, and it causes so much pain. And these patients will get like gallbladder ultrasounds, oh, you have some sludge, so they'll wait a few more months, and actually it's all the congestion. And they get restless, and they can't sleep at night because there's too much of the fluid in their lungs. And then the heart is not pumping well, so what are the blood coming out through the heart, through the aorta, is very minimal. That's not enough to perform daily activities. So that's why they feel fatigue, very lethargic, depressed, and when the cardiac output, the blood flow through the aorta gets less and less, they suddenly pass out, syncope, and sudden cardiac death happen. And also the other common finding in these heart failure patients is because they no longer can eject the blood enough, so the heart beats more faster. Generally 70 is the normal heartbeat per minute. So they try to beat like 100 to make up the extra blood that the body needs. And with the higher heart rates, it's commonly noticed that they can develop some palpitations and extra heartbeats. So now, so far, heart failure is a clinical diagnosis. No single laboratory test can find this patient has heart failure. So clinically, you tell your symptoms to the physician, and the physician diagnoses your heart failure. And the lab tests are complementary, and they help finding what is the underlying cause for this heart failure. So the few tests that I would do when a first time a patient presents to my clinic are, I would do the blood count to see what's their hemoglobin, do the kidney function, and what is their creatinine, and what are the potassium and magnesium. Do they have high potassium? Then certain medication can be dangerous. And also make sure you do fasting blood glucose, because diabetes can be one of the cause. And thyroid function test. Too much thyroid, too less thyroid. Thyroid is one of the important organ of our body that we should take care of, because thyroid can cause atrial fibrillation. Thyroid can cause pericardial effusions around the heart, and also thyroid is the other cause for heart failure. So thyroid is one gland in the body that we should take serious. And also iron studies. So now coming to BNP. So I would like to say a few words about the BNP. So this is the test that if someone comes to the emergency room, oh, I've been coughing, I have allergies. Or, oh, I don't know whether it's my COPD, my asthma, or my heart failure. All you have to do is simply by doing this test, you can, if the BNP levels are less than 50, you can very confidently say like you do not have heart failure. And if the BNP levels are more than 100, well, there is 83.4% that you may very well have congestive heart failure. So this test you can use any patient that comes with shortness of breath and can easily say that this patient cannot or may have congestive heart failure. That's called brain natriuretic peptide or BNP. If you have any of these symptoms, please make sure you ask your doctor to run this test. And then if they present to the hospital, so they get a chest x-ray, and here, so here you see all these like whitish streaks with the fluid-filled lungs. And an electrocardiogram, it tells us how bigger are the ventricles and is there any thickening of the ventricles, so you can tell on the EKG the changes about the heart. And then finally, coming to the echocardiogram, this is a very valuable test. So here again, looking at the heart, so right atrium, right ventricle, left atrium, and left ventricle. So they should be very robust. And here, this person has a heart function normal. We call this as ejection fraction, 55. And anything below 49, 45, we call congestive heart failure. And then again, like, we make them into grades. And this patient has heart function around like 20%. And before moving to treatment, it is very, very important. You need to know two things. One is how much is the ejection fraction, and then the classification. How do you classify the congestive heart failure patient? So here, heart failure with anyone who has, I said normal ejection fraction is 55. If anyone has less than 40, then we call congestive heart failure. If it is 41 to 49, we call borderline. And if it is 35 to 49, we call medium, moderate. And then if it is below 35, we call like severely depressed heart failure. And this is very, very important. So we need to know the stages of the heart failure. So what is stage A? So stage A is if anyone has hypertension, diabetes, or if anyone has undergone the chemotherapy for cancer, they come under stage A. So these patients should be monitored so that they won't go to stage B, C, D, and they can get effectively treated at the very beginning. And then stage B is, okay, they started to, so these stage A patients are monitored, and they started to see changes in their heart, left ventricular muscle, started to get weak, but they do not have any symptoms of heart failure like congestion or cough, edema in the legs, or fatigue, so none of them. They just have this disease, but they're asymptomatic. And C is structural heart disease, which is congestive heart failure and the echocardiogram with their ejection fraction less than 40%, and also they have symptoms of heart failure. And then stage D is they've been treated with all the medications and we are exhausted, so now what? But advancements has happened in congestive heart failure. Now we have therapies for stage D as well. So I quickly go through NYHA stages. So stage C, who develop the symptoms, they can be, their ejection fraction can be 10, 20, 30, 40, but none of them behave like sane. So they can be class 1, they can be asymptomatic, or they have only symptoms with moderate exertion. And just with ordinary physical activity, so it causes mild shortness of breath, but otherwise they're fine. And stage 3 is they're symptomatic even with minimal exertion, so they can walk to their bathroom, so they can go to their patio without getting tired. And stage 4 is like they're symptomatic even at rest, so these are the patients in the trouble. So why do we care about these classes? So number one, what to treat, when to treat, so they help us. And also, if you look at the class 1 and class 2, they have congestive heart failure and they think they're fine, but what's happening at the end of the 1 year? Out of those, 5 to 10% of them are dying at the end of the 1 year, just be having a congestive heart failure, not being symptomatic. And stage 3 with symptoms, so 25% are dying by the end of the year. On stage 4, more than 60% are dying by the end of the year. So this is very important to know where a patient lands in terms of the NYHA class. So what can we do to treat congestive heart failure? So we do have medications that we need to treat these patients. And American College of Cardiology and Heart Failure Society has came up with the guidelines. There are 4 medications that these patients should be offered and treated when they have congestive heart failure. And before going to medication, so the American College of Cardiology and Heart Failure Society also recommended some non-pharmacological interventions. When you see your heart failure first time, make sure you teach them heart failure education. So what is heart failure education? So heart failure education is teaching them how they can be treated medically with these 4 medications that I just mentioned. And also, they need to be given instructions. These patients can take only 2 grams of salt because their body is already retaining salt and water. If they take more salt, more fluid they're going to retain, and which is more detrimental. So they need to be educated about self-care. So they check their daily weight so that they know when they gain weight and how much they gain weight and how much fluid they can take. Every heart failure patient to know about the self-care. And also when they can increase their medication, when they can decrease their medication based on their blood pressure. That's education is called self-care. Number 2 is there was a myth in the past that, oh, you have congestive heart failure, you cannot do anything, just stay in the bed. It's no longer true. It's in green, that means we have to do is exercise training. So every individualized patient should be assessed for exercise and should be given appropriate, at least to moderate activity for these heart failure. Because the mortality rates have gone down, those who had done the activity. And salt restriction is reasonable in these patients. Again, if these patients have obstructive sleep apnea, they should be offered a CPAP treatment. And again, cardiac rehabilitation can be very, very useful in these patients to improve their quality of life, to improve their functional capacity, and also to improve their exercise duration. So cardiac rehabilitation plays a very good role. So now coming to treatment. So what are the treatments? So we already talked about fluid and salt retaining. So the first thing when they come to the hospital or when they come to the clinic with the symptoms, we give them a water pill. So what does it do? So there are 3 or 4 varieties of water pills called Lasix, hydrochlorothiazide, torsemide, and bumetanide. They all do one job. So they send the fluid out of the body and make the patient to feel better. But the question is, can they improve their length of their life? So they can only treat symptoms, but they cannot they cannot increase the longevity of their life. So they are only for symptom improvement. And then there are a few other medications that the heart failure patient should take, and they do increase the length of their life, and they do have a mortality benefit. So last 2-3 years, we've been hearing even in the TVs, there is a new medication for heart failure. It's called Entresto or Sacubitril. So this medication was tested in the trials, and it's proven that this medication reduces the hospitalization and improves the quality of the patient's life. So that's why it's in green. And all green we must do to the heart failure patients. So these are the guidelines. So any patient who has a chronic symptomatic heart failure, either NYHA class 2 or 3, they should be given, offered this medication Entresto, or they can be offered either enalapril, lisinopril, or they can be offered, if they're intolerant to that, so they can be given losartan. And these are the medications that we can use. And the medication benefit only be given to the patients when these medications are given at the maximal doses. So if these medications are given, oh, I've started my heart failure patients like a tiny bit of the medication and he's been on that for 4 years, we're doing no good because these medication doses tested in the trials is maximal, and we should be seeing this patient more frequently and increase their medication doses. And so this is the one group. It's called ACE inhibitors. The most common name is enalapril or lisinopril. If they're intolerant to this medication, we can move to either losartan or valsartan. And then if someone's ejection fraction is less than 35, so they can be given spironolactone or eplerenone. And beta blockers are the major therapy for the congestive heart failure, but only 3 beta blockers are approved for the congestive heart failure, either bisoprolol, carvedilol, or metoprolol succinate. So these should be given at the maximal doses. And African American patients, hydralazine and isosorbide are proven to be very, very better medications. And next, so why is this medical therapy is very, very important for these patients? So if you look at this, the first class is called ACE inhibitors. And here, to reduce hospitalization 31%, and we should treat 26 patients for 36 months, and then you can reduce 31% of the hospitalization. If you look at this hydralazine and nitrates, if you just treat 7 patients, you can reduce 33% of the hospitalization. It's amazing. You can prevent someone from coming to the hospital to feel better. So these medications should be offered to every single patient who is symptomatic. So going to the other pharmacological, so forth, I told what to do, and now I tell you what not to do. So nutritional supplements as a treatment of heart failure are not recommended in patients with current or prior symptoms of the heart failure period. It's red. Don't do that. If you have trouble taking 10 pills, take out all the nutritional supplements. Take the real ones that can strengthen your heart. Take the real one that can decrease your heart rate. Take the real one that can improve your blood pressure. So these nutritional supplements in the past were given, like macronutrients, they help your heart, but so now don't do them. Hormonal therapy, other than to correct deficiencies, are not recommended to patients with current or prior symptoms of heart failure with reduced ejection fraction. And hormonal therapy is proven one time, hormonal therapy is very good, but we learned our lesson that hormonal therapy is causing blockages in the heart, and also in the heart failure, they're not very good. So hormonal therapies are no longer recommended. And there are few drugs that adversely affect the clinical status of the patient who has heart failure. So when could be some of the diabetic medication, they actually exacerbate the heart failure symptoms, which are thiazolidine-dienes. Just taking the pain medication can exacerbate the heart failure symptoms, so which are Aleve, Motrin. If someone has heart failure, it's safe to take other pain medications rather than NSAIDs, which could be Tylenol is more safer in these patients, which by means pain medications, I'm not talking any pain medications. And then moving on to the therapy. So we talked about the medications. So what else? So what are the new advancements in congestive heart failure? So let's say a patient has congestive heart failure for the last 12 years. He's been on the medications and he comes back, I am getting my feet swollen all the time. My water pill does not work anymore. And I take it high, I get weak. I take it low, it's not enough. So how do I know that my water pill is enough for me? How do I know I get appropriate treatment for my heart failure? So in the past, what we were doing before is like, okay, check your weight every single day, check your blood pressure, make sure you take this medication. But now you don't have to do all of them. So we got this one to do everything. It's called CardioMEMS device, or it's a PA sensor delivery system. a small butterfly. So what we can do is we go from the groin, from the venous side, and we can lead into one of the artery that connects to the lungs, and it stays there. And all patient has to do is he lay down at home. He gets a special pillow after this implant, and every morning or afternoon he just lay down on the bed and he just transmits the pressures to my office, and there I can just, oh, Mr. Smith, your pressure is low today. Go down on the medications. Go decrease your Lasix to 20 milligrams. Or I say, hey, you know, your pressures are going up consistently last 1 week. You're on vacation or having some salty diet. Yes, that's true. So then we can go up on the medication. So this medication can be altered more easily once we have this system in place. And it can be used for both failure with reduced ejection fraction and heart failure with preserved ejection fraction. And this is a game changer. And then, so because when the heart muscle is weak, so the right side and the left side, they're not synchronous, they're not happy couple anymore. So if that's the situation based on the parameters, so we can offer them a biventricular pacemaker, a defibrillator, where so this small device sits in their chest cavity, and the wires goes from there, and one goes into the right ventricle, one goes behind, and it can make the two ventricles, the lower chambers, beat at the same time. And what it does is it improves the heart function and also symptoms over the time. So here, interestingly, look at this heart, so bigger, and look at this EKG, more wider, right? So with this bilead pacing, now it's gotten smaller, which is good. And look at this EKG, so it's gotten more narrow. So that means they responded very well to this bilead pacing, and their symptoms are improved. Yeah, and then stage 4. So a patient has heart failure for, let's say, even with the 2 years, or someone has heart failure with 10 years, they've been on the medication, but now they got to a point where they just cannot get out of the bed without symptoms. It's called advanced heart failure. They've been on the medication. We offer them everything. So now I have nothing to offer. The patient comes, hey, so I want to live longer. I have things to do. I have family that I need to take care. So what are my chances? As of today, his chances are pretty good. And this is what we call mechanical pump, or durable pumps. This is what the first picture Dick Cheney got, so mechanical pumps. What it does is, this ventricle is so weak that it can no longer pump and it can no longer take the pressures. So this pump can actually take all the blood from the left ventricle and puts into the aorta. And where does this get power? This gets the power from this battery. So these patients can just function like us. And I went to Disneyland last summer with my children, and I have seen not 1 to 3, more than 5 patients with the LVADs vacationing with their families, no limitations, and so much fun. And all they have to do is they need to change the battery at the end of the day. They go home, charge their batteries, and if the batteries runs out, it make noise, and they do know when the batteries need to be changed, and they can be effectively manage their life. And these are the patients, they were told that they were dying a couple days ago once this machine in, so they function so much better. And then this pump can be done while waiting for a new heart, which is called heart transplantation, or this pump can be done as a destination therapy. Okay, so we're not going to do transplant, but we'll put pump in you, and that's the rest of the life. And when the patient decides, okay, I'm done with my life, and that's the end. So that's about the heart pumps. And finally, the heart transplant. So this has been there, the heart transplant, but we have not gone too forward with this heart transplant because the organ availability is so low. and still, like, it's not surpassed more than 1,000. So patients waiting for the heart transplant list is growing, but the availability of the new hearts is has increased since the past. So this is one of the best methods to treat the advanced heart failure patient, but at the same time, lack of the organs make the patients wait while waiting to die. So that's all about heart failure. So now, coming to the part, okay, so what can we do not to have any of these therapies, right? So this is overwhelming, and having hospitalization, caregiver stress, and changing the family dynamics, having a heart failure diagnosis can be very depressing. And so in order to prevent all these, what can we do? So to prevent the heart failure, we first need to know what are the conditions that cause the heart failure. So either hypertension, which is high blood pressure, diabetes, smoking, obesity, diet, or physical activity. So how can we beat them so that we won't be in the heart failure cloud? So high blood pressure, now there is a new guidelines, American AHA, American Heart Association, in November 2017, they said any blood pressure above 130/80 is high, and they're called hypertensives. And nearly, based on the definition, half of US adults are classified to have high blood pressure. So how do someone know that they have blood pressure? By checking it. Everyone should know their numbers. Everyone should check their numbers, starting from 40 years, starting from 30 years, starting from 20 years. With the proper treatment and management, they can live a long and healthy lifestyle. An ounce of prevention is worth a pound of cure. That's my saying. So now with their American Heart Association 2017, what is normal blood pressure? If anyone has less than 120 and 80. And if someone has more than 120 to 129 and less than 80, that's called elevated blood pressure. Then they go on to the stage 1 if they have 130 to 139 and 80 to 89, the bottom numbers. And then they go to stage 2 if anyone has higher than 140 and the lower number higher than 90, they have high blood pressure stage 2 period. It could be 160, 170, it's a high blood pressure. Then we call hypertensive crisis if the top number is more than 180 and the bottom number is more than 150. So that's a critical situation where patient can. Yes, please.
Just one quick question I have. Is in people of different that are 60, 70, 80, or 100,
Yes.
what is the systolic? I read this in a magazine the other day. The systolic is the more important number
Yes.
versus the diastolic. Of course, it's important, but this is my question.
Very good question. So for younger people, the bottom number is very, very important. But as someone grows older, 40s, 50s, 60s, and 70s, as their arteries get more stiffer and stiffer, the top number gets more important, and that's what we need to treat in the older population. So that's systolic, that's correct. And there are 2 studies how to treat the older individuals. So one study mentions let's leave the blood pressure alone. But when we left the blood pressure alone, they were having more strokes, they were having more heart events. So now the latest guidelines is let's treat them in one way. So let's treat the blood pressure more stringently so that they don't have any strokes or any heart events. So that's the new guidelines.
And does it go up? Question, just follow up. Does it go up every 10 years?
Yeah.
So what do you you're aiming for still 120 in the
120.
systolic?
Yes. Yeah. But in older individuals, like let's say 70 or 80, if they cannot tolerate 120/80, so we will have a liberal like 130/80, but more than that, it's need to be treated.
130/80.
Yes. Yes, please.
So what if only the lower number is higher, like 87, but the
Yes. So if the lower number is 87, that comes under the blood pressure stage 1. So what we need to do is not necessarily treat them with medications, but we can suggest them to do the diet and lifestyle changes so that these lower numbers can go down. Is that your question?
yeah, because that's me. My the upper number is 120, it's
Yes.
normal,
Yeah.
but the lower number is 87.
Yeah.
But is that count as a high
Yes.
blood pressure?
So yes, this is counted as like, blood pressure stage 1. Yeah, and again, so the blood pressure treatment starts with diet and lifestyle changes. And if that does not help, and then we would move forward to the treatment. So why we need to treat these numbers? Because when your blood pressure goes up 87 or 90, the lower number, that means that you have high blood pressure and your heart has to effectively work against these pressures. So that means your heart is working harder. Yes, please.
You mentioned the thyroid. Take care of it. How do you take care of your thyroid?
Okay, very good question. So thyroid illness can be two varieties. One is thyroid hormone secretes very low, or thyroid hormones can be too much in the body. So if it is too low, you supplement and you give medications to that person. But if the thyroid hormone is too much circulating in the body, we need to find out, does this patient has any situation like goiter? This patient has what's causing it, like, one nodule causing it. So based on that, they will be treated. They will be given iodine, or they will be given radiation. So, or they will have surgery based on the underlying condition for causing the higher thyroid hormone. So we will see the underlying condition. Yeah. And now coming to the cholesterol. It's a big elephant in the room. All right, so how do you define cholesterol numbers? So based on the new guidelines, there is no single cholesterol number that's given to every single that's given to the population. So what we need to do is we measure the cholesterol, which is a 4 parts: total body cholesterol, that's a type of body, total blood cholesterol, that's correct. And then HDL, which is a good cholesterol, LDL, the bad cholesterol, the triglycerides and the batter. So these cholesterols need to be measured first. Once we measure, so we need to take into account that individual, and also we have to calculate a risk score. It's called atherosclerotic cardiovascular risk score based on their risk factors. The risk factor is this patient has high blood pressure, and how much is the upper number, and if this patient has diabetes. So you plug in all these numbers and you assess this risk score for every individual. If it is less than 7.5, your chance of having next 10 years any heart disease or stroke are less. If it is more than 75, so then your chances of having a stroke or heart disease in next years are high. So what causes this cholesterol to go up? So especially the triglycerides, if you look at, being sedentary causes the triglycerides to go up. Please move every 1 hour. If someone's sitting in the sofa for more than 1 hour, that's not normal. That's not normal, so we got to move. And obesity, overweight, and even excess alcohol causes the triglycerides to go up. And high carb diet. And so the HA recommendations are starting from age 20, everybody should check their risk factors and check their cholesterol. And so coming to the diet, I think we're nearing our 7 o'clock, so I'll just go through. So any diet, so just don't think like what diet I should do. Any diet you do consistently, do for long term. That's what this research is showing. So this is the Mediterranean diet. You get the benefits of the Mediterranean diets when you do daily physical activity, so it has to be combined. So Mediterranean diet is you use like grains and fruits, vegetables, and here you only eat meat monthly. That's what the Mediterranean diet. And it's all showing that the heart failure incidence is low when you take these diets, including this is the DASH diet. And so again, like here, they're comparing all the, so 1 year changes in the body weight as function of the diet group for all study participants. They were all equal. So one diet is not superior to the other diet when it's consistently done. So instead of thinking which diet to do for 1 year, just do one of these diets for 30 years, which you can see best results. And then, yeah, so these are, so obesity, again, this is one of the other risk factors where 1.4 billion adults are overweight and 500 million are obese. So let's look at the Utah really quick. So this is a self-reported obesity among US adults. And so this is 25 to 30% of young adults in Utah are obese as per their report, self-reported. So now this is non-Hispanic white adults. So in Utah, the non-Hispanic white adults are 22 to 25%. Again, so non-Hispanic black adults, 30 to 35.
Colorado.
Yeah, and now self-reported obesity in Hispanic adults by state and territory is, by Utah here, is 25 to 30%. So I thought that Utah will be having this stipulated here because everyone seems to be exercising, everyone is healthy, but still there is a reported obesity which is self-reported. This is the best. And physical activity and AHA recommendations. So these are my last slides. So what physical activity I need to do? Again, please do not think any physical activity that one can do will be good. But these are for overall cardiovascular health, 30 minutes of moderate intensity aerobic activity per week, total of 150 minutes, and at least 25 minutes of vigorous activity for 3 days, and moderate high intensity activity for rest of the 2 days to make up 5 days. So this is what recommended. For just lowering the blood pressure, so an average 40 minutes moderate vigorous activity, 3 or 4 times a week. So again, the questions is like, I don't know what is moderate intensity activity, I don't know what is vigorous intensity activity. So here are the moderate intensity exercises: walking briskly, water aerobics, bicycle slower than 10 miles per hour, tennis, ballroom dancing, or general gardening. Vigorous activity: race walking, running, swimming, tennis, aerobic activity. If you bicycle more than 10 miles per hour, so that's vigorous activity. Jumping rope and heavy gardening and hiking. So conclusion, let's all live longer, and also let's give our children a better society, not the society with epidemic of heart failure and cardiovascular disease. Let's start the primordial prevention. Let's offer them the healthy habits. So how do we do this? So we, like Simple 7, manage your blood pressure, control your cholesterol, reduce your blood sugar, get active. No longer than 30 minutes in the sofa, we have to stand up and walk. And eat better. The colorful plate makes healthier. Lose weight, stop smoking. And thank you so much for all your patience. And any questions I will take now. But before that, my 2 patient champions patiently waiting here. Thank you so much for coming. And I would like to invite Jackie to the podium. So I have seen Jackie on one of those Fridays before I got ready to go home. And Jackie came in with shortness of breath, and we have here. Yes. All right. So Jackie, and she has done everything that she could do to be at the stage. We only offer choices and we only offer few treatments, but it is her positive attitude and positive role got Jackie going stronger at her age 95.
Well, I don't know what to say other than the fact that I've lived this long, so I feel like I've done something right. You know, when you see the things that she's put up that you should do, start doing it, and every day, try to keep a happy, positive outlook on life. Always look at the glass of half full, never half empty. And I think maybe thinking these good thoughts, you can get past the bad things that come along. A lot of it is a lot good luck. So you can't discount that, but a lot of it is taking as good a care of yourself as you're growing up. I've just been kind of lucky. There's always that, you know. But I do appreciate being here and at this age to walk up here and to do as well I will by golfing and bowling, and I've walked a lot. I don't walk so much now, but just keep up the good work, ladies and gentlemen. You know, you're going to live a lot longer than you might think, so take really good care of yourself. Very nice, thank you.
And my second patient champion I would like to introduce is Maria. So Maria has one of these rare stress-induced cardiomyopathy. So Maria has a stress-induced cardiomyopathy, and she was treated in 2009 and again treated recently, and she recovered pretty good. And again, like Maria also has done so well with her treatment, but it's all her positive outlook. So I will have Maria for a few words.
Hi, I'm Marina Hudson, and I have heart failure, cardiomyopathy, and this is my second time. I had it the first time in 2009 at the age of 39, lived an entirely healthy life as a youth, vegetarian, physically active, and something comes out of the blue and it's idiopathic, and at the time I researched heart failure and cardiomyopathy on Google, and boy, the hits you get back in 2009 were not so good, but now it's a lot more information is out there, and thank you, Dr. Nalabottu, for having these seminars to provide more information for folks that are suffering with it. And I have to tell you, there's information out there right now that is about how you live your life, and I noticed you said instead of diet and exercise, you said diet and lifestyle changes, because lifestyle changes include stress management and positive mental health. And these are things that are very, very important. And my number one message for anybody living with heart failure is exactly that. You can live with heart failure. You can live a very physically active and very high quality life with heart failure. It is not something that you're gonna sit by and just kind of live with and go into a depression about. So I guess the most important thing is, for me, my self-neglect has been stress management. And one of the things I learned from Jon Kabat-Zinn, who is one of the innovators of mindfulness-based meditation, is a quote that I think is very applicable. And that quote is, "As long as you are breathing, there is more right with you than there is wrong." And that rings true with so much. And if you or a family member is going through life with heart failure right now, I just wish you positivity and strength as you go through this heart failure journey. So, thank you, Doctor.
And before I conclude, I would like to invite one of our physician champions to the podium, and it's Dr. Scott Hacking.
office with the most wanted list, and so this is impromptu, and so I remember in med school I learned to do two things very, very well. One, I can make anyone pee. Two, I can make anyone poop. And so part of heart failure treatment is making people pee, and she covered that very, very, very well. Heart failure it's amazing how much heart failure we actually see now. And largely it was simply, I can make you pee in the past. That was pretty much what we offered people in the past was, well, you're retaining water, I can make you pee. Whereas now, as she went over so well, there's so much more to it, from treating with specialty medicines, to causes of heart failure, to putting in stents, which is what I love to do. I love to put in stents and pacemakers and do procedures. Those kind of things help people get better from a procedure standpoint, to even more invasive, going the extra mile to those bigger pumps that can go in and transplant. So there's a whole spectrum of treatment rather than just live with your heart failure and I can make you pee. So I've learned a lot more since med school about how to treat heart failure, and you learned a lot more tonight than I learned probably even my first couple years of med school, because now there's such an emphasis on heart failure. Never before would I have ever thought that I'd have a partner who treated heart failure. I'm like, well, I already told you I can make you pee. Now I have a partner who, when I have someone that's tough to treat in heart failure, I can send them to Dr. Malabothan and tell her, I've done all the I can make you pee stuff, you do the rest. And she can help them get better. And so those of you who are out there wondering about symptoms of heart failure, it's so much more complicated, and so nice that you're here tonight looking at causes. And I'm grateful to have a partner that I can send people to who have difficult to control heart failure.
Thank you everyone for coming and taking your time, and the message is be happy, live longer. And I would like to thank our practice manager, Tony, and Jess, and Rachel, and Yosh, everyone who put together this program to be successful. Thank you so much. And if you have any questions, please, should we send an email?
They're on those cards.
Okay, great. Yeah, please send me an email. I'm more than happy to address more in detail. Yeah.
Thank you.
All right, great. Thank you.